Hello, colleagues. I'm Dr. Tat-Lam LUK from Yanchai Hospital. Today, I would like to present my study as pilot study that assesses the potential of oral myofunctional therapy for improving sleep disorder breathing in adult patients. I have no conflicts of interest to disclose. Sleep disorder breathing is common among adult population in Hong Kong. It is the wide spectrum comprises of snoring, upper airway resistance syndrome, and obstructive sleep apnea syndrome, which affect sleep quality and has certain impact on quality of life. Oral myofunctional therapy is a set of techniques and procedures intended to exercise the facial and oral muscles to improve proprioception, tone, and mobility. It was introduced by orthodontics over 100 years ago as corrective exercise to stimulate growth in the maxillofacial region and influence proper occlusion. These video clips are the maneuvers that patients will learn in oral myofunctional therapy program. First, pucker power, which aim to train masseter and pterygoid muscles. Some trainings will make use of small materials. Button pull with the help of the string to train the buccal and peroral muscles. Marshmallow twist with the help of string to do the exercise. This video shows the training of tongue muscles by different maneuvers. This is called monkey with an upward push of the tongue against the upper jaw. Lip tracing is asking the patients to make a circular movement of tongue around the inner lips. Wiggle the spot, another maneuver to stimulate the training of tongue. This is tongue depressor push-up. As the name suggested, oral myofunctional therapy is indeed like a gym section to train up the tongue and oral muscles and strengthen up. In recent years, multiple literatures, including pilot study, reveal patients to systemic reviews, are trying to demonstrate that oral myofunctional therapy promoted improvement in subjective symptoms of daytime sleepiness, sleep quality, quality of life, and also oral facial malfunctional status. However, it is still not commonly practiced in Hong Kong, and there are no relevant local studies on this topic. Therefore, the objective of this study is to evaluate the application of oral myofunctional therapy to adult patients with sleep disorder breathing in Hong Kong. This is a pilot study, prospective in nature. It was a one-year training program from September 2018 to September 2019 in Kowloon West Cluster. The inclusion criteria are those patients diagnosed with the sleep disorder breathing or snoring concern, age equal or above 18 years old, and willing to enroll in the training program. For the methodology, before the start of oral myofunctional program, each patient had a sleep study to record the initial respiratory disturbance index. They are also needed to fill in two sets of questionnaires, namely Epworth Sleepiness Scale and Functional Outcomes Sleep Questionnaires, which I will talk about them later in more slides. This is the schedule of the one-year training program. Each patient had 4 sessions of oral myofunctional training in the first 8 weeks of the study. Patients were then asked to continue the oral exercise twice daily to achieve improvement for sleep disorder breathing. Physiotherapists will review them in week 17. In yearly visit, which scheduled on week 12, 26, and 38, we will check if the patient remain compliant to home exercise, ask if they have encountered any difficulties or imperfection, and also explore on factors on non-compliance or dropout. We will also ask patients to fill in the questionnaires to monitor progress. For the yearly visit, patients' body weight will record. There are 3 outcome measures, including daytime sleepiness by the Epworth Sleepiness Scale, sleep-related quality of life by the Functional Outcomes Sleep Questionnaires, and the change in Respiratory Disturbance Index in the sleep study. The pre- and post-therapy results were compared by using the Wilcoxon test. These are the validated questionnaires of Epworth Sleepiness Scale and functional outcome sleep questionnaires in Chinese validated version. The Epworth Sleepiness Scale is to assess the daytime sleepiness. Higher the score, more daytime sleepiness the patient is suffering from. The functional outcome sleep questionnaire is used to assess the functional status in adults with the impact from sleep disorder breathing. A total of 30 questions on different aspects of daily functions or activities were asked. Lower the score, more impact on quality of life. Higher the score, higher the quality of life. 12 patients were included in the study initially. One male patient dropped out as he deflated multiple sections of physiotherapy training. 11 patients had full completions of physiotherapy training and 1 year follow-up. Body weight is a significant confounding factor in the study. Body weight was measured for each patient at a regular interval during the program. It's found that the change of body weight is very minimal for all patients during the course of oral myofunctional therapy. This slide shows the change in Respiratory Disturbance Index. This table shows descriptive statistics. The average RDI decreases from 19 to 13 after intervention. By looking at an individual subject, among 11 patients, 7 of them shows a drop in post-treatment RDI. By running the Wilcoxon test, p-value is 0.328, and this is statistically insignificant. The Epworth Sleepiness Scale is to assess the daytime sleepiness. Higher the score, more daytime sleepiness the patient is suffering from. The average score decreases from 8.8 to 7.8. 6 patients had some benefit from oral myofunctional therapy by having a drop in the score in Epworth Sleepiness Scale. After running the Wilcoxon test, the p-value is equal to 0.368, and this is statistically insignificant. For the functional outcome sleep questionnaires, lower the score, more impact on quality of life from the sleep disorder briefing. Higher the score, better quality of life. So if the patient have a positive value after comparing post and pre scores, then they are doing better after intervention. We can see there are 6 patients out of 11 have positive value after intervention. However, there is only minimal change in average score from 18.2 to 18 with p-value equals to 0.79, and this is regarded as not statistically significant. It is concluded that the finding in this pilot study shows some positive effect from oral myofunctional therapy. The result, however, did not yield statistically significant results. In this study, we tried to collect feedback and opinions from patients. Here are some major replies, including difficulties to find time for practicing. Some can only use some time to practice during travel or even during toothbrushing. And it's also inconvenient to get all the practicing materials. Some simply said that they are lazy to do the exercise. And new questions arise after this pilot study. As one of the most busy cities in the world, is Hong Kong a practical environment to have oral myofunctional therapy? I think these questions can only be answered by having a future large-scale study on oral myofunctional therapy. With the fruitful experience from this 1-year program, there are a few recommendations for the future large-scale study. Patient compliance is the major challenge. It's not easy to ensure compliance of patients on oral myofunctional therapy, despite the fact that we have already offering regular follow-up and physiotherapy training to monitor progress. Technology can be helpful at this juncture. Zoom functions has been gaining more and more popular in the past 1 year for different kinds of meetings and congress in COVID period. By having a Zoom sections between patients and physiotherapists, it's easier to have more follow-up and progress monitoring through the computer screen. Apps can be another good assistance. There is already a study showing apps can be effective in delivering oral myofunctional therapy to improve obstructive sleep apnea. Apps can be used to record the frequency of practice. It can also send notifications to remind patients if they have been absent from training for a period of time. By centralizing data from all patients, if there's any patient who is far behind the others, some notifications can be also sent to patients to remind him, which act as an incentive to patients. These technology can be used in further large-scale study, especially in COVID period. Some modifications to training content can be considered for using those training tools, which is commonly disliked by our patients and considered as not convenient. At last, I would like to thank Dr. Lee and Dr. Ai for their support and guidance, and physiotherapist Ms. Leung for her help. Finally, I would like to thank all patients for their participation in this one-year study. Thank you all.